Hi friends, thank you for tuning in to the Concussion Coach podcast. I'm Bethany Lewis, the Concussion Coach. I'm a neurological occupational therapist and certified life coach, and I specialize in guiding people through their concussion recovery journey. I am passionate about helping people understand their injury, speed up their recovery, and reclaim control over their life post-concussion. The purpose of this podcast is to help increase awareness of concussions and the impact they can have on a person's life, and to bring hope to people who have suffered a concussion and those who love them. I firmly believe that sharing stories and knowledge about concussions will bring important light and understanding to this misunderstood and often invisible injury. The information in this podcast is meant to bring that awareness and hope and is not meant as medical advice. The opinions shared are those of the interviewees and my own. If you are suffering with lingering concussion symptoms, I have created a concussion coaching program specifically for you. I will be your mentor to guide you through your recovery journey, offering help with understanding and managing your symptoms, setting achievable goals, and learning how to manage your own thoughts and nervous system in order to get control over your life again. If this program sounds like something that would help you or someone you love, sign up for a free consultation. In the consultation, you'll get valuable information and resources and gain hope for your future. Sign up for your free consultation at the link in the show notes or at my website, www.theconcussioncoach.com. Hi friends, welcome back to the Concussion Coach podcast. I am so excited for this discussion today and have a funny story to tell you about how I met my guest. My family and I went on a road trip this summer in our 12-passenger Nissan van. It's large and very noticeable, and I made it into a mobile advertisement by having my logo and information on the windows. And you can see it on my social media if you're interested. Just look up the Concussion Coach on Facebook or Instagram and you'll see posts about it. Anyway, at the end of our road trip, we stopped by Crater Lake in Oregon on our way back to Utah, and we were not there for very long. And my children were a bit feral because it was the end of the vacation, but it is absolutely beautiful and I would totally recommend going. We even saw bears we were driving in. Anyway, the next day I got an email from someone that I'd never met before, and you can just imagine my initial confusion and then delight when I read this. I'm going to read you the email that I got. I was hiking Crater Lake Trail east of the lodge and came up on a lady who fell and hit her knee and her head. Her daughter was a nurse and said they were fine, not on blood thinner, no other symptoms at the time, but she was being escorted off the trail by rangers. I thought it was crazy. I saw your van on the road of Crater Lake. Who knows? They might see your van pulling out and give you a ring. I'm a vestibular PT, been doing it since the year 2000. Also a neuro and concussion therapist, but mostly dizzy. Anyway, thought your van was cool and thought I would give you a heads up just in case. I'm heading to the top of Watchman's Tower now, Andy. It was like, I just like reading that for the first time. I was like, wait a second, what? This is so cool. So I love how those of us in this space support each other. And I love the connections that I've gotten to make in this space, especially through the randomly through the advertisement on my van. So that's how I met Andy. And I'm very excited to get to know him better and to learn from his years of experience in this field. So I'm going to just read you his bio really quick and then welcome him officially. So joining us today is Andy Beltz, a physical therapist based in Northeastern Ohio, right down the road from the Pro Football Hall of Fame in Canton. With 26 years at Aultman Tusc Therapy, where he also serves as assistant manager, Andy has worked with over 20,000 patients fighting dizziness and balance disorders. Andy is passionate about finding innovative ways to solve complex multifactorial dizziness cases by fixing atypical forms of BPPV and optimizing nervous system health. In addition to his clinical practice, he is an adjunct faculty member at the University of Mount Union, has served as a clinical instructor for 31 PT students, and has taught over 60 continuing education courses on vestibular rehabilitation to other healthcare providers. Fantastic. I am so glad that we ran into each other, kind of. So thank you, Andy, for being here.
Yes, thank you for having me, Bethany.
Yeah.
Your van is awesome, by the way. I was like, oh my gosh, this is meant to be.
Right? It was meant to be. So great. Thank you. And I do love that van. When we first were like considering buying it, I was so afraid that I would be too afraid to drive it because it's massive. But then I got in it and I was like, oh, actually, I really love this. It's my favorite thing.
That'd be great with family.
Yeah, it's good for road tripping. It's been a lot of fun. I'm grateful for it. So let's just start by hearing more about Andy Beltz. So where are you from? How was your road trip? Because that's how you were also on a road trip and when we ran into each other. So
well, thank you for having me, and hello everybody. I'm excited to talk with you all and Bethany tonight. So I'm from Ohio, Northeastern Ohio. Like we said, the Football Hall of Fame. I work about 5 minutes away from there at a large nonprofit hospital, and we met. The way we met, we were doing an out west trip. My wife has said she'd rather collect experiences than anything, so we love to travel. We love to take the kids on crazy adventures that we kind of drag them through the trails, and they have a good time. but then want to go home pretty fast. But we have good memories there. We recently did that road trip. We flew into Seattle, and then we ended up driving a total of 3,000 miles. It was so exciting and exhausting, and I think we averaged like 20,000 steps a day hiking. So it was really cool, though. So many beautiful places out west. Utah is awesome. I mean, I would love to do that like 10 times a year if possible.
Right.
So, but yeah, and but the crazy thing is, and I don't want to ruin this, but when we flew into Seattle, we had our first medical emergency that we had to assist with. So I'll kind of give you some details on that. But when I was hiking up Cascade Mountain, I was actually running. I like to run, trail run, and my way of running is very slow. So don't imagine this guy sprinting and being in amazing shape. I'm just like moving faster than walking. But I then come up on this lady who was sitting on a rock, and there were two people standing around her, and I'm like, oh, maybe she sprained her ankle. So I'm like, oh, ankle sprain, and before I tell more about that story, about what I do next, I guess I'll tell you about the medical emergency at the airport, because then that'll explain why I did what I did when I was up on the mountain. So at the airport, we were getting ready to rent our vehicle, and I looked over, and this lady was in the process of passing out. So she was standing there. She's like, all of a sudden, she slouches, like the daughter, I assumed it was a daughter, like caught her. I run over, and I wanted to lower her to the ground because I'm thinking, is she having cardiac arrest? What's going on? This other person comes over and kind of takes charge, very authoritative kind of person, and says, oh no, don't take her to the ground, put her in this chair. And I'm thinking, okay, I'd rather get her on the ground, but I thought this person must know something I don't. I didn't know who they were from Adam. We try to get her to wake up, trying to feel her pulse, trying to assess, does she have a pulse? Is she breathing? And she was kind of starting to come to. My wife is a physical therapist. As she was kind of coming to, in and out, I could kind of feel her pulse. It was kind of high, but nothing major. And my wife said, let's get her some crackers. Does anybody have crackers? Some peanut butter crackers. And the person who kind of came up and was kind of trying to take charge, and I thought must have been like a doctor or, like an emergency department nurse or something, said, oh no, you can't give her crackers. And I'm thinking, interesting. So the person is kind of still just not waking up. I started to try to ask family, what kind of past medical history do we have here? Is there diabetes, whatever? They said, yes, there's diabetes. She'd been standing in the airport. I'm thinking, why can't we do crackers? And she's still in and out. And my wife's like standing there like, when this happens in the nursing home, we give crackers. And the person usually does what? Like to me under her breath. And I'm like, tell me. So I tell the person who's kind of taking authoritative kind of charge is like, tell me your medical background again, and he's like, oh no, I don't have any medical background. I'm like, oh, I said, well, we need to give her crackers. And then I explained I'm a physical therapist. I'm not an emergency person, but right now that seems like an appropriate thing to do. Obviously we're worried about her choking or something like that, but we didn't think that would happen. So anyway, we gave her crackers. She came to, the squad came, they still took her to the hospital, but everything ended up okay. But so now fast forward to the mountain. The lesson learned there is, I think when we come up on something like that, it's helpful to say, anybody have a medical background here? Just to try to triage or prioritize who takes over.
Yes. Yeah.
So anyway, I'm running up the mountain. I see the lady sitting on the rock. It looked like a sprained ankle. For some reason, that's what came to mind. And the daughter said, which I didn't know was a daughter, but then it came out later, no, she fell, hit her leg, and hit her head. So then I'm like, whoa, this suddenly went from sprained ankle to possibly something very wrong. And so I said, anybody have a medical background here? And the daughter said, yes, I'm a nurse. We've got it under control. Kind of like I had a feeling like she was saying, don't bother me. So then I'm running up, keep running up the mountain, and my imagination just starts going crazy. Like, what if she has a bleed? How hard did she hit? What if there's a neck problem? Is her neck stable? How much did the nurse know? So I cut the run short, turned around, checked. They were having communication, whatever, talking. It didn't seem like it was as bad as my imagination started thinking on the way up the hill or on the way up the mountain. And so I just asked, any blood thinners involved? No. And she was talking, she was communicating, she was doing fine. So then I'm running down the mountain, And then my imagination started running more, and I'm thinking, what if this is like their first night here at, Cascade Mountain, and this is such an awesome place, Crater Lake, and this is such an awesome place, and what if she has like BPPV, and what if she could be fixed, and man, all we'd have to do is, a few maneuvers, and she could still enjoy her vacation, and so anyway, we drive out, and I see your van, and I'm like, maybe the concussion coach can save the day.
Maybe.
They see your van being with that advertisement. And I guess I'm kind of an idealist and a dreamer a little bit. But so anyway, that's how this all came about. I looked you up, I Googled you, found your website. I thought, I'm going to shoot her an email quick. Maybe she'll check it, and sure enough, you did. And I think that's when we connected. I was up on top of that trail that had that gorgeous view, and it was amazing. So
so awesome. I love it so much. I'm just so grateful that you did send me that email and we get to connect here. This is a topic like your specialty is something that I think is so important for us to get out there and talk about. And I haven't done a ton of, there is one other episode that I did with somebody who specializes more on the vestibular side of things, but I feel like we can't get too many out there. So this will be so good. I'm so grateful. And I love your helper heart and mind. you're there to help, and I think that's a beautiful thing.
Well, I brought props, so I have some cool toys that I can show, and things that we use in the clinic. Because you kind of asked, how did I get started? When in the year '99, I started working in the acute care environment, and there was a local ear, nose, and throat doctor, Mark Vogelsang, awesome guy. He had an audiologist, Richard Dickerhoof. And they had started a Dizzy program with my sister, who's a physical therapist. Long story short,
a lot of PTs in your family.
Yeah, my parents had no opportunity to escape our wrath. So our poor kids, it's
I love it.
rough on them. But so anyway, my sister ended up having to move on she was starting her own family. So I got to know Dr. Vogelsang, Richard Dickerhoof, his audiologist. They were awesome. They sent me patients with dizziness on a consistent basis. They mentored me weekly for hours. They were available to talk. Like looking back, this was late '99, early 2000. I didn't know what I was getting, but like I was probably getting like a residency, like a vestibular residency kind of per se.
That's so cool.
They sent me patients regularly. I went to 2 courses at Emory University, some long courses that you had to pass to say you were competency based. Aultman, my employer, was amazing. They bought me the equipment I needed, something that I'll be talking about. I can't see my video, so I don't know if you can see these, but these special goggles, can you see these okay?
Yes, I can, but go ahead and describe them in case people are listening instead of looking at the YouTube video.
Yeah, so something that's really important, and I'll explain more as we go on, is being able to block the ability of a person to focus. Our eyes are the windows to our inner ears. So the inner ear, I guess I'll go ahead and go with this. And then if you want me to stop, just tell me. Our inner ear is tiny. Okay. So this is the outer ear. And everybody thinks the inner ear is the part that the doctor looks in. And it's not. That's the outer ear. And the inner ear is deep in your skull. So it's kind of back behind your temporal bone. And I don't know if you can see it. It's tiny. You can put 4 sets of these on the end of your thumbnail. That's how small it is.
And I go the bones from the inner ear there? Is that right?
Like the semicircular canals, the utricle, and the saccule. So I've got some other inner ears here. I love to collect inner ears. I'm such a dizzy nerd.
I love it.
But you can kind of see the canals are not nice and round like most models would say. They're kind of like bent bicycle rims. And inside this part of the inner ear, we have little calcium crystals, little rocks that are supposed to be inside there. They shift forward and back and up and down, and they move our eyes. So it's crazy. I'm still amazed by this when I talk about it every day. I'm still amazed. Our inner ears move our eyes. So when you hit your head, you get a concussion, you knock these rocks loose. Oftentimes, my mom had it happen, and that makes the eyeballs spin, because what happens is those little calcium crystals that are supposed to be in here fall out into these tubes, and each tube moves the eyeballs in its own plane of motion, which is amazing. And the calcium crystals fall out, and that spins the eyeballs. So we can see when a person is dizzy.
Hmm.
And so there's more ways that the eyeballs move in ways that they shouldn't, and we have different ways of testing those. But here's the point. Aultman, when I first got started, bought me the equipment I needed, which was these crazy glasses. Now this is like my seventh pair because I've been through so many because they wear out, they break. We actually have 6 pair of these in our clinic because we see so many people with dizziness a day, which is why I call myself the Dizzy Busy PT. We're just dizzy busy. But we fixate, we stop the patient's ability to fixate. I don't know if you guys can see this, but there are cameras inside.
Hmm.
So you have people put these goggles on, and then I have a giant screen in all our different exam rooms where patients put these goggles on, and I watch their eyes. And so I have learned after seeing thousands and thousands and thousands of patients' eyeballs, I have learned patterns and ways that the eyes should move and they shouldn't move when a person has had a concussion, when they have any kind of neurological condition, when they have peripheral vestibular problems, meaning inner ear problems, or when they have brainstem or cerebellar problems, like brain type dizzy problems.
Hmm.
Even right before people pass out, their eyeballs move in special ways that you can see what's coming or what's happening. So the this is science. I love art, don't get me wrong. I love the art of medicine, but this is not art, this is science. But we have to combine art because we don't know all the rules yet of what all these eye movements mean. But we do have a lot of rules that help us know what different eye movements, how they should be and how they shouldn't be. So anyway, I got those goggles and saw amazing things and got to do vestibular rehab for about 3 months. I thought I was a miracle worker that I could fix everyone. And then after that, it's like everybody got hard after that. So for the last 26, 25 and a half years, I've learned that you cannot fix everybody, but there are special maneuvers, there are special types of therapy. There are people like yourself that we can consult for help to optimize nervous system health. There's so many different things that come into helping people who are dizzy. So
Yeah.
it's been an amazing ride.
I love it. It's such I can tell your passion for it, and I love that. I love
Trying not to be over the top because I do love to talk about it. But so if I get a little carried away, just reel me in.
I can so relate. It's great. It's fantastic. I think it's a wonderful thing. So tell us how, like, I think it would be helpful just because dizziness is one of those significantly distressing symptoms that people often deal with who've had concussions.
Yeah,
So when let's talk for a second about the different kinds of dizzy that there are, if that's okay. So
sure
I know
is.
that when people say that, they can mean so many different things. So I'd love it if you could just kind of break down for us what some of those might actually be. If someone's saying they're dizzy or they're off,
Right.
what are the options for what that could mean?
Yeah. So I love that you asked that question because I love to talk about this. I'm fascinated by this. So after year 15, okay, all I did was see dizzy patients every day. Patients with dizziness. I don't mean to be disrespectful of, depending on your preferences with language. But there came a point where I'm like, I felt like I was interrogating my patients. Okay, we learned that the most important question in the history, back in 2000, we learned that the most important question was, what do you mean by dizzy? What does dizzy mean?
What does
Okay,
that mean to you?
because what we were taught was that if the patient says spinning, think inner ear, think brainstem or cerebellum. Okay, so if it's spinning, think vestibular problem. If it's lightheaded, we were taught lightheaded meant like a pass out feeling. So think heart, think blood flow, think anything that would stop blood flow from getting to the brain. And then if it was off balance, only when they're sitting, think neuropathy, think a problem from the neck down. Well, I knew I had to find out, what does dizzy mean? And we were told that 70%, Joel Goebel, he was an ear, nose, and throat doctor. He said 70% of patients can be diagnosed by history alone. Well, I wanted to be the best dizzy therapist in the world, back in northeastern Ohio. So I was like, I'm going to find out what dizzy means. What do patients mean when they say they're dizzy? Well, it became like an interrogation. It was almost like I had a light over my patients, and I'm like, "Where were you on Monday night at 7 o'clock?" And the patients would get intense, and I would get intense, and this would happen for hours every day because I'm trying to find out. What did the patient mean when they said they were dizzy? And they struggled. They struggled answering that.
Yes.
And so I got curious and I started to think, what do patients mean when they say they're dizzy? And I started to alphabetize all the descriptions they would give me. And I kept a spreadsheet. And I thought, okay, I got 50 different descriptions. I won't get more than 50. Then the number kept going. I had it alphabetizing for me. And I started, instead of dreading all these crazy words that I was getting, I don't mean crazy disrespectfully, there was just a huge, vast variety of dizzy words that patients were giving me. I thought, I won't get more than 70. Well, the list kept going. And Bethany, I'm up to 465 different descriptions of dizziness, and I don't keep track really anymore. I just
Are you
add the
kidding
I add the unique ones.
me?
Okay. Like I had a
Wow.
lawyer, and I love lawyers. I have family who's lawyers, but he said dizzy to him felt like he was a turd. I'm like, I didn't say it, and like I said, I love lawyers, but there's some funny descriptions, and so you learn a lot. Like people use discombobulated, discombobulated, foggy, fuzzy, full pressure, heavy, off kilter. Like you're spinning down a mountain in a barrel in the third dimension while you're flying off a cliff in the fourth dimension. And I'm thinking, what does all this mean?
It's a very good question.
So then new studies came out that said, whoa, whoa, whoa. What do you mean by dizzy is important? Okay. But what's more important is triggers and timing.
Hmm.
Focus on triggers, focus on timing. And so the burden lifted after about year 15. It only took 15 years
That's all.
for me to calm down, playing Tai Chi music in the background, trying to stay chill during the histories. Oh, and I don't, the patients always ended up, we were both had a mutual love and respect for one another. We'd hug, at the end. But it would just get intense. So here's the point. Dizzy can mean anything that somebody wants it to mean. Lightheaded doesn't mean what most healthcare providers think that it means. Most patients use the word lightheaded to describe off balance. They don't know that lightheaded means a feeling like they're going to pass out.
Huh.
So now I start with, when they come back, I start with triggers. Do any of your sensations get worse when you lay down, when you roll over, when you bend over, when you tilt your head back? If yes, and I always say beware of the trap of it. When I'm taking my history, I don't say what makes it worse. I say what makes the exact sensation that they're describing worse, because patients homogenize their symptoms.
Yes.
I had a lady last week who had 7 different dizzy descriptions. She had had a concussion. She had 7 different dizzy descriptions. And she said for 12 years, nobody had helped her. Well, the truth was is she was lumping all those symptoms together for the one thing, and some of the symptoms were better sometimes and some weren't. So the word dizzy means anything that a person wants it to mean. But what we have to focus on is, what are the triggers? And another way that I like to start histories, I kind of depend on what the patient looks like. I look at their chart. They fill out a dizziness handicap inventory. It's extremely helpful. I look at those answers and I decide if I'm going to start with triggers or timing. So sometimes I start with timing. They'll be sitting in front of me and I'll say, do you feel a sensation of dizziness just sitting here right now as we speak? That would tell me if it's constant, if it lasts hours, minutes. Okay. So dizzy, then I ask what the description is, but then that's like naming your kids. You name your kids so you can keep them separated, so you know which one is into art and which one's into sports, and which one has blonde hair, that kind of stuff. So dizzy means anything a person wants it to mean. We care what it means, but we care more what triggers it, how long it lasts, when it started. Okay, there are a lot of different characteristics that we ask. But to keep it simple, spinning, vertigo, okay, vertigo, people say, oh, I had vertigo. I would say 50% of the people who say they had vertigo do not have vertigo. Vertigo means spinning.
Okay.
People will say, like I had a patient today, they said, oh, my vertigo started back up. I said, oh, tell me more about that. Well, it's just off balance. He actually, I I tested his vestibular system. He passed all of his vestibular tests and he almost passed out in the parking lot when I walked out with him because he's orthostatic. That's not vertigo. He
Okay.
truly was about to pass out. That's lightheaded. But
Got it.
patients don't take all these classes. They and to be fair, here's what else is crazy. I had dizziness. I had vertigo in the year 2012, and I've had it because I have migraines. So, and here's what's crazy. When I had it, I struggled describing it.
I don't, that's really unfortunate. But like, I just think that it's
I
good
thought,
for people to hear that. Like, probably just like reassuring, like, okay, even the pros, the experts, it's when they're experiencing it, it's just hard to come up with the words to, yeah, that's super
I should
interesting.
say I was able to describe the spinning easily. When people are spinning, they don't have to stop and think about if they're spinning.
Mm.
If they have to stop and think about if they're spinning, they're probably not.
Mm. Okay.
They're probably feeling more like they could spin, like something could happen. I call that the pre-spins, the uh-ohs.
Mm.
That usually represents a second phase of vestibular disorders.
Okay.
Did I answer your question?
Fascinating. Well, okay, so you maybe let's talk a little bit more about the vertigo since we're on that.
Okay.
So
Yeah,
vertigo means spinning specifically.
right. So
Um,
vertigo, true vertigo means spinning,
okay.
and it's not a diagnosis.
Okay.
So patients come and they say, "Oh, I was told I have vertigo." Well, that I don't know what that means, to be honest. I've
Okay.
tried to figure it out. I think that when a doctor tells a patient they have vertigo, they're saying that there's nothing serious going on. Maybe 80% of the time they mean there's nothing serious going on, but it's
Mm.
really not a diagnosis. It's a symptom. That's like if you came to me and said your back hurts and I told you that you have back pain. Did I tell you why you had back pain?
No, you did not.
No. So it's the same. Like if patients go to their doctor and they're told you have vertigo, the next question that would be great would be to ask the doctor, well, what does that, why do I have spinning?
Hmm. Hmm.
Just to get the answer for what the doctor means when they say they have vertigo. And that
Yeah.
probably won't happen.
Yeah.
But the point is vertigo means spinning.
Okay. And
And
how long, like if somebody has vertigo, how long is there a typical amount of time that the spinning like lasts, or is it totally variable?
so since concussion is the purpose of your YouTube, let's
Yes.
talk about the three most common possible reasons that a person who's had a concussion might spin.
Perfect. Yes, please, let's do that.
So there are three major vestibular syndromes:
Okay.
acute vestibular syndrome, triggered episodic vestibular syndrome, and spontaneous episodic vestibular syndrome.
Okay.
If I'm worried, if a person's had a concussion, if they're in acute vestibular syndrome, these are the people who've had such a horrible head injury that their labyrinth has been destroyed and they are going to spin for days,
Mm.
even if they hold still and do not move. Okay, that's so if you're a patient and you're listening to this, you have to kind of be careful how you answer this. If you are holding still and not moving and you're still spinning, it might decrease in intensity, but the spinning continues. That means that the spinning is constant. That would be acute vestibular syndrome if it lasts 24 to 72 hours. And in the context of a concussion or a head injury, that would be like a true labyrinthine concussion.
Can you describe really quick for our listeners what the labyrinth
Yeah.
is?
So basically, for instance, I've had patients who've been kicked by horses, who have fallen off of four-wheelers, construction workers who had pins fall from the bridge and hit them in the head where their labyrinth was actually fractured.
And the labyrinth is those semicircular
Yeah,
canals.
it's these semicircular canals inside their temporal bone.
Mhm.
Gunshot wound, bam, going right through the jaw. You could see the path.
Jeez.
So it actually damages the labyrinth so bad that it makes the nerve hyperactive.
So, and that's why they feel like they're spinning.
And they spin, and anybody who looks in their eyes at that point, if they are truly in acute vestibular syndrome, their eyes will be slamming with nystagmus.
Mhm.
Okay. So these are really bad head injuries. That shouldn't be confused with a traumatic brain injury that causes cerebellar or brainstem damage. That will also cause nystagmus, but the direction of the nystagmus will be different.
And nystagmus, why don't you define that for our
Oh, I'm
listeners as
sorry.
well? No, you're good. I just want to make sure that I
So-
understand you, but I want to make sure everybody is
Yeah.
on the same page.
So nystagmus is an involuntary eye movement that has a fast phase eye movement followed by a slow phase eye movement.
Mhm.
And the direction of the nystagmus can be any direction, but its direction helps us know if a patient has had a head injury, like the lady on the mountain. I so badly wanted to look in her eyes. And I kind of was. I was kind of like, trying to sneak a peek because I'm like, if she has something vertical, I know we've got a bleed going on in the brainstem.
Mm.
So you can tell the direction of the nystagmus. If a person has a head injury and then vertical nystagmus, that's an emergency. They're probably already on their way to the emergency department.
Mm.
Okay. So we know by the rules of these fast phase followed by slow phase eye movements, what kind of damage has been done to the balance system. The balance system is made up of the vestibular system, which has a peripheral and a central part.
Mm.
And so as a dizzy therapist, I use all these special bedside tests, looking in the patient's eyes and putting the goggles on to determine, is it their inner ear and or their brain? So, the concussion trajectories, the 6 concussion trajectories. I want to know if there's a vestibular part, a balance part to the concussion. I'm going to do all these special tests.
Yes.
And so I'm going to watch their eyes so that then I can know in the moment, and then 2 weeks from now, a month from now, after their head injury, did they have acute vestibular syndrome? Did they have a labyrinthine concussion? Or then I go to my next options, triggered episodic vestibular syndrome. Okay. The most common reason that a person gets spinning after a head injury or triggered spells of dizziness after a head injury is when the calcium crystals fall out and they go into the tubes where they're not supposed to go. Very, very common.
Okay, so it is common for the initial traumatic experience, like the hit to the head or whatever it was, that will knock loose those crystals.
Yeah, super common.
Okay.
Super common, very common. So, and the really cool thing is, a lot of times that can be fixed with special maneuvers or special turns of the head to put those calcium crystals back. But it often gets overlooked in the emergency department because when you've had a head injury in the emergency department, we want to make sure you're not dying.
Yeah.
So that's going to be priority number one. And the patient's got neck pain, they got headache. They're not interested necessarily in being tested for BPPV at that time, benign paroxysmal positional vertigo, where the rocks get loose. That's what it's called.
Mm-hmm.
So that's triggered episodic vestibular syndrome. That's the second major reason why a person after a concussion would get dizzy. And that's the most common one.
And by triggered episodic, that means like if you move your head in a certain way, that's the trigger, and it's episodic because it happens randomly. It's not a constant thing.
Yep. When you move your head, okay, so it's most common. Listeners could do this. They could know, like, if you were to go into your home right now, go into your bedroom, and you were to lay flat, would you get dizzy? Now, my person today said, no, I don't get dizzy. I said, do you lay flat? Well, no. I sleep with my head up on 2 pillows. Well, why? Because I'll get dizzy. Okay, let's
I love it.
lay down, take the pillows
the questions to ask. It's like you've been doing this
speed.
for a while.
Yeah, do it at normal speed. If
Yes.
you avoid laying flat for any reason, it's probably because you've had rocks loose in your head. And I say that respectfully. So, and then you can also test it by rolling right, rolling left.
Mm-hmm.
Those 3 movements will work for screening patients for BPPV probably 60 to 70% of the time. They're not perfect tests.
Okay. And the dizziness that they would be experiencing if they moved in those ways would be a spinning. It would feel like spinning.
Many times, but with exceptions.
Okay.
I sometimes like to say, if anything intense happens in your head when you lay flat or when you roll over, and if that intense feeling goes away in a minute or less, it's very likely calcium crystals loose.
Okay, and that's good to know too. So it's short-lived if you stay in that same like you move in it and then the crystals move and once
Yes,
they settle in, you should stop feeling dizzy.
yes, with exceptions,
Of
but
course.
most of the time.
Okay. Okay, fantastic. And that triggered episodic vestibular syndrome, is that the same thing as BPPV?
Yes, it's a form of, so BPPV is a form of triggered episodic vestibular syndrome.
Okay,
There are other reasons for triggered episodic vestibular syndrome, but in the context of concussion,
that's usually what it is.
think BPPV.
Okay. I'm learning so much. Thank you. This is great. Okay.
Awesome.
Let's
And then the third reason would be vestibular migraine.
hold on.
So
Sorry. Did we talk? Is that the same thing as the spontaneous episodic?
yes, so spontaneous. So we talked about acute vestibular syndrome being like a labyrinthine concussion, as in the context of concussion, that would be the kind of spinning that lasts, or intense dizziness. That one would be spinning usually. That one would last 24 to 72 hours. Then there's triggered episodic vestibular syndrome, which is the BPPV. Then you have spontaneous episodic vestibular syndrome. When a person's had concussion, especially if they have a history of migraine, especially if they have a history of migraine with aura, they can be a little more likely to have vestibular migraines. And there can also be some damages to the inner ear that can mimic Meniere's or hydrops. And those are all forms of spontaneous episodic vestibular syndrome.
Okay.
So something I'm passionate about, if any patients that you would ever coach say they have these attacks of dizziness and nobody can figure out why, and that they last minutes to hours, ask them to video their eyes during the attack. You hold up your phone, you turn on your camera, and you hold up your phone so you can see the eyes real big during the attack. And I have helped patients get diagnosed who've been so frustrated and so lost so many times because our cameras on our phones are one of the best vestibular tests that we have available.
Fantastic.
So
Who knew?
you can see the nystagmus during these attacks. If patients have BPPV at home, I wish that emergency departments would video patients' eyes during their attacks so that people like me, once they get to outpatient, could see what was happening.
Yeah.
So we
Yeah.
knew what was going on.
So tell us more about the vestibular migraine. What is that exactly? And
Yeah.
what does it look like? What does it feel like for the patient?
So if you've ever had migraine with aura, and I have, it's a basilar, vertebral basilar type migraine where you lose vision. Okay, you start to see little sprinkles, little crescent moons, little bubbles. You can call them all kinds of things. And that aura is a blind spot. But we don't know it's a blind spot until you've had them enough where you know it's a blind spot. And that is the optic migraine. And many patients have a headache after that. And it's horrible. And it causes motion sickness, it causes nausea, it's miserable. Well, if you have that type of migraine, you're like 5 times more likely to have a vestibular migraine. And most people know about the optic migraines. And when they hear about optic migraines, sometimes they know that, you're going to have the visual stuff and then you're going to have a headache afterward. But sometimes they know you won't have a headache afterward. You'll just get the visual stuff and you'll feel kind of yucky for a while, but you don't get the headache. What people struggle with when we talk about vestibular migraine is the same way they get the aura, they can get spinning. So instead of the migraine attacking the eye system, the migraine attacks the vestibular system, the balance system. And so the person will spin as their aura. So the aura lasts 20 minutes, with the vision, usually aura lasts 20 to 30 minutes, plus or minus. The person will spin for that long.
That's fascinating.
There'll be spontaneous attacks. And it's because of chemical events that are happening in the brain. And we're learning more. We thought it was vasoconstriction of arteries, and we think it's like chemicals that aren't being processed properly. So there's a lot of different theories. We're making progress, but we still don't know exactly. But we do know that when a person's had a concussion, they're maybe more likely to have post-traumatic migraine type symptoms. And if they've had a history of concussion with migraine, they're also more likely to maybe experience some of these kinds of migraines. It can be a trigger for vestibular migraines. They're
Okay.
horrible. They're scary. Many people didn't know about it in the last 20 years, started to know more about it the last 10 years, starting to know more about it now, starting to learn how to treat it. But it can cause inner ear damage.
Oh, really?
Yeah. So what's crazy is, and this is where it gets confusing, you can have a concussion, you can have post-traumatic migraine as one of your trajectories, you can have a vestibular migraine, and then that can cause BPPV, or it can cause a hypofunction, or it can trigger the vicious cycle of dizziness that many people think of as 3PD, persistent postural-perceptual dizziness. So I like to say you got to know what the trigger is. You got to know what the cause is. You got to prevent the cause. And that makes it easier to get out of the vicious cycle of dizziness and heal from post-concussion syndrome.
Yes. This is why it's important to talk to somebody who understands all of this. I can see why patients are, it's so confusing for people. And especially
Yeah.
if they just know they're dizzy and they don't like talking to somebody who really knows matters.
Yeah. And what we tend to do is we lump all of these symptoms into one, but it's not. I call it the dizzy pie. It's a dizzy pie. You imagine a pie, there are several pieces to the pie. Their pieces are different sizes. So you have to fix each individual piece of the dizzy pie. And the only way you can do that is if you know what all the different pieces are.
Yes.
So you have to figure out all the different concussion trajectories that the person is in, and then you have to figure out all the different reasons for their dizziness. And then you slowly pick away.
Yes. Okay. Well, and I appreciate that you are making it sound like there is hope, like, that there are things you can fix each of those.
Yeah.
You have to know what they are and know how to fix them individually.
Right.
So I would love to chat about that in a second, but I'm curious. I don't know, with vestibular migraines, you said that the aura, the spinning is the aura for that. It's about
Right.
20 to 30 minutes ish. And then
Right.
do they have a headache after that as well, usually?
This is where it gets confusing and people want to kind of battle the idea that it's a vestibular migraine. They may have a headache and they may not.
Okay.
So the migraine classification system requires certain criteria must be met. So technically, and here's what else is frustrating. You can't get a diagnosis with this unless you've had like 5 to 6 attacks that follow all these rules. So it gets hairy. So if you're watching this video, and you're thinking, that's it, I gotta have vestibular migraine, slow down, because it takes time to accurately get a diagnosis. But symptom characteristics, triggers, timing, how long they last, what makes it happen, does anything provoke it, or is it just there? And then did you have a headache afterward? Those kinds of things can help us, the neurologist or the general practitioner, whoever's taking over with the official diagnoses, formulate a diagnosis and help get the right treatment.
Got it.
That can be a process. So if you're listening to this, don't get discouraged. If you feel like your doctor isn't listening, because they are, most likely they are listening, but this takes time, because they don't want to make a false diagnosis and give medication that the person didn't need.
Yeah. Yeah. Yes. Well, and I think that it's even just understanding what you're sharing, I think will be helpful for people to know that, like, what kinds of things to be logging. If we're trying to like understand and be able to report to the doctor what's going on, having like knowing what the triggers are, if there's a trigger, or if it just happens randomly, which I assume if it seems to just come out of nowhere, that would be more of the spontaneous episodic one, right?
Yeah, so right. So if it's spontaneous, meaning it just comes on for no reason, there wasn't a trigger. Think that would be in that setting of spontaneous episodic vestibular syndrome.
Yeah.
And so what I would say is, to keep this simple, if you're a person who has a concussion and you have like chronic symptoms, like you're always sensitive to vision, like you watch things move and it makes you dizzy, well, that means you're more in the vicious cycle. Your brain is sensory reweighing, it's it's paying too much attention to your eyes. That's not one of those three syndromes. But if you're having a sudden attack of something intense that is either triggered or spontaneous, then you're not just in the concussion realm. You're having something in addition to the concussion happening.
Okay.
But the concussion might have been the cause.
Yes.
I don't know if that makes sense.
Yeah, no, I think that's, yes.
You can have cognitive fog if there's a cognitive trajectory. You can have eye discomfort if you're trying to read, or blurred, or you can have dizzy feelings trying to read because of an oculomotor part, a convergence issue. You can have neck pain making your head feel foggy, fuzzy, full. If you've got a cervical issue, if you have anxiety and you go out in public and then that makes you feel all these funny feelings, that could be an anxiety trajectory. But we work all those out. That's all part of the dizzy pie. And we treat those all differently.
Yes, yes, yes. Thank you so much for clarifying all of this. I would appreciate if you would help us understand the 3PD as well. How is that different than what we were already just talking about?
So I'm really passionate about this. I witnessed 3PD before it was a diagnosis. Susan Whitney out of the University of Pittsburgh talked about the vicious cycle of dizziness in the 2000s, early 2000s. So I just called it the vicious cycle of dizziness. And here's what would happen. You'd hit your head, your rocks would get knocked loose. Your brain would say, oh, I can't trust the ear. I'm going to rely more on, there's a dizziness trigger, okay? I'm going to sensory reweigh, just like you would if you sprained your ankle, you're going to limp. Well, your brain is going to look for ways to limp, to protect the bad part, okay?
Good way to describe it. I love it.
So it's going to upweigh input from the eyes. You're going to become more visually dependent. What that means is you're going to get dizzy watching things move. And that word dizzy could be nausea, it could be yucky, it could be motion sick, it could be anything you want it to be. You might also be light sensitive, okay? Then the body is also going to upweigh information from your speedometers in your neck, okay? Your neck, right at the base of your skull, has the highest number of speedometers and GPS systems, okay? Speedometers, like tell your head how fast it's moving and where your head is, GPS. In the base of your skull, the occiput in the first two cervical vertebrae has the highest number of muscle spindles and Golgi tendon organs. That's the fancy word for speedometers and GPS systems of any other muscle in the body other than your eyes. So what happens is your brain gets hurt, your inner ear gets hurt. Your brain says, well, I can't trust the inner ear. I'm going to rely more on the eyes. I'm going to rely more on those sensors, not only in my neck, but in my feet. Well, that's fine. But what happens is the unconscious becomes conscious. We start to feel normal movement. We become hypervigilant. We feel things that we never felt before because we never paid attention. But our brain is asking us to pay attention now because it doesn't trust our voluntary system, our unconscious system. Our brain doesn't trust our unconscious involuntary system. I'm sorry, I misspoke. Involuntary. Yes. So we try to take conscious control over an unconscious event. And we begin to feel normal movement is abnormal. And we don't like that. It makes us feel dizzy. This is all the vicious cycle. This is 3PD is what I'm telling you. So if you don't use it, you lose it. You start to want to avoid because you don't like feeling these sensations. Your neck gets tense because you don't want to move your head because you don't want to get dizzy. You get more headaches, cervicogenic headaches. You're not moving and you feel miserable. And now, because you're not using it, you lose it. And now when you do move, you feel weird. You start to feel even more sway, more motion, kind of how I feel in the glass tower, on the glass floor in a tower like in Seattle, It's like a fear of heights kind of on your own 2 feet. You might feel it on the edge of a cliff on a trail. Our patients who are in this feel it on their own 2 feet when they're walking. And then they develop anxiety, and the anxiety creates dizziness. And the anxiety promotes more of that sensory reweighing. And so it's the vicious cycle. And that's 3PD. But I am much slower now to blame things on 3PD than I was 5 and 10 years ago. And here's why. with those special glasses that we use when I test people, what I'm learning is they have micro forms of vestibular dysfunction that we used to say were just normal artifactual problems. And we'd say, no, you don't have any problems. Your brain's just not adapting. You're stuck in the vicious cycle of dizziness. You have 3PD.
Hmm.
And the recovery is still the same, but patients who perceive themselves to have 3PD sometimes I don't know if that's helpful for them to think that, because they perceive it as though they have a brain problem, like there's something wrong with their brain. And it's not that they are emotionally or psychologically bad or that they're doing something wrong. But what I'm seeing is there are actually inner ear disorders that exist that's keeping them in that vicious cycle. And once they understand that, it like removes the burden off of their shoulder, which stimulates their parasympathetic nervous system, helps calm them down, and it helps set them up for habituation and what has to happen to get out of the cycle.
Yeah. Holy cow. That was so well described. Thank you for explaining that. The brain is so freaking cool and crazy.
Yeah.
And all of the systems of the body, like it is miraculous and amazing and also can be so confusing. So thank you for sharing that. Like I think that would be very helpful for people to hear and understand. Can you remind us what do those three P's stand for three?
Persistent postural perceptual dizziness.
Okay. Okay. Persistent postural perceptual dizziness. And it is
So
not
3PD, PPPD, which can be confusing because of BPPV, which is benign paroxysmal positional vertigo.
they're different things, but
Yeah.
sound similar.
So yeah, and I just want to say that most likely if someone watching this YouTube video, they might be more likely to be type A because they're looking into why they're still having this problem. So if they're taking the time watching this video, they might be a type A, maybe they might tend to have that trait, or they might really want to be in control. And so we know that people who have those personality traits struggle with this more. But what I've learned is when you do a thorough vestibular exam, when you find some of those subtle, what I call micro forms of nystagmus that are symptomatic when you're doing your tests, when you explain that it's more than just 3PD, that you've got inner ear damage, like you hit your head really hard. Like it's not you not doing the right thing that's causing this not to go away. You're going to have to learn to live with possibly some damage to your inner ear. It kind of sets realistic expectations. And expectations are the enemy of serenity. Patients who have this, who are in 3PD, sometimes think that if they just get it right mentally, or they do the right thing, that it will just go away. And then when it doesn't, it keeps them in a sympathetic state, which keeps them from optimizing their overall health.
Yes. Which is exactly like I can just see it being so hard and confusing because you're like, okay, I have to relax. It's kind of like when people can't fall asleep and they're like, oh my gosh, I have to sleep, I have to sleep. And then you prevent
Right.
yourself from getting to the parasympathetic state where you
You
can
can't
actually
force
relax
yourself
and
to sleep.
Yes, yes.
And
So
sleep hygiene is a big part of this.
yeah, yes. As you were describing that whole vicious cycle, I was like, oh, nervous system. This is
Yeah,
all about how it affects our nervous system and how we can
for real.
do that. And that, yes, the personality traits of the type A, like wanting to be in control. Man, it's so, I see all the time. Like this is the way you're describing is just beautiful and summarizes so much of what I see and who I work with. But it's like and it's such a beautiful thing. People who are like, I'm going to make this recovery I'm going to do everything I can. I'm going to find out what to do. Like, and there's a part of that is like so helpful and so good. Like you want to be able to figure out what to do, but then there's such an important part of letting go and letting it be like, but it's so hard to find that balance. And
So Bethany, that's where I go. Like I assess my people who are in this situation. I say, are they rehab ready?
Mm.
Are they rehab ready? are we ready to do the habituation where I'm making them do these exercises and I'm making them dizzy on purpose?
Mm.
Well, if they're not sleeping and they're only sleeping 2 hours a night and they're running hot
Mm-hmm.
and they're a nervous wreck, maybe those exercises are being overprescribed or maybe at too high of an intensity. And
Mm.
maybe the expectation with those exercises is wrong, only making it worse. So then I look at nervous system therapy.
Tell us what,
So,
yeah, what do you do? How do you?
so I love the nervous system. I'm fascinated by it.
Me too.
So, we have several different ways, and this is where I phone a friend, somebody like you. I would, I would probably recommend counseling, psychologist, psychiatry, whatever is most important.
Mm-hmm.
But I do my own part too. I did Tai Chi for arthritis. Paul Lamb, he's a medical doctor who teaches Tai Chi from Australia. You can take his courses online. You can look him up on YouTube. We train the nervous system with all kinds of things, side breathing, Tai Chi, different types of techniques. I try to meet the person where they are. I encourage optimizing spiritual wellness, spiritual health. Try to talk about, mantras, podcasts. You've got to treat the spirit and the mind, but it's not, I don't believe, I think people take it too personal, like they have a mental problem, when oftentimes I think they were born like a Yorkie. You think of a Yorkie, it's hyper. Think of a golden retriever, they're more laid back. Like we have these different traits that we were born with that kind of put our nervous systems in a state where maybe we're more likely to be more on the sympathetic side or more on the parasympathetic laid back side.
Mm-hmm.
So I work on aerobic training, strength training, spiritual training, mental training, Tai Chi. I think of it like if a person has a psychological problem, they go to a psychiatrist. The psychiatrist has to work hard to find the right cocktail of medications with the right dosages, the right medication, taken at the right time, and adjusted accordingly. And so to treat the nervous system with non-pharmacologic options, it's a cocktail of activities. Sometimes it might be a hill run that just beats the crap out of you and makes you so calm and relaxed after it's over because you don't have the energy to be stressed. And somebody listening to this might be like, well, how in the world am I going to do that? I'm not in a physical condition to do that. And you're right. If you're not in the physical condition to do that, then we have to pick something else. But sometimes it might be a gratefulness journal. Depending on your spiritual source of strength, sometimes it might be worship music, or it might be inspirational music, or it might be small group time, or it might be time with a counselor, or it might be reading a certain book, or it might be a mantra, that speaks to your heart, that helps you calm down. And the crazy thing is, it's a minute by minute battle. And unless you've been in it, you probably don't understand. And it's a lot to ask in some cases. So it's hard. But that's kind of how I approach it. So we have Tai Chi. We will prescribe Tai Chi. I will work on sleep hygiene. Neck therapy. Okay. Neck therapy, in my opinion, treats the nervous system.
Hmm.
In my opinion, soft tissue work, optimizing neck health, C1, C2, it stimulates the parasympathetic nervous system.
If it's done right and by somebody who knows what they're doing.
Boom.
Yes.
So,
Yes.
dry needling, all the things, whatever works for the person, EMDR, whatever works for the person to help them find a level of peace.
Mm.
And ultimately what we're trying to do is improve sleep, because I can't make a brain that's running out of battery habituate to a bad ear from a concussion unless we're getting sleep. Sleep is when healing happens. So sometimes my focus is simply on, as a physical therapist, optimizing health and wellness so that the person sleeps, so that they get rehab ready, and then I start official vestibular rehab.
This is, I like can't even tell you how much I appreciate everything you're saying right here. Like this, like everything you're saying, I'm like, amen, amen, amen. Yes, yes. Let's shout this from the rooftops. Like, get this to everyone. All therapists who are working with concussion patients need to hear this. All patients need to hear this. This is, I like so much of that resonates. And I feel like like you listed, I've come up with what I've like determined the 6 pillars of concussion recovery, and they are nervous system, physiological, mental, emotional, spiritual, and social. Like
There
all
you
of
go.
those are key, and the
Yep.
brain being impacted impacts all of those things, and we need to address all of those things in order to help recover the brain. Like it
Yes.
just, yes.
Yes. And we
I,
need to be patient and understand that it takes time.
yes,
So yeah, and I like to say we got to try softer, not harder.
yes,
It's not about forcing it.
yes.
You have to learn to try softer and relax through it. Don't tense through it. You have to learn to go green when you move, turn it off, don't turn it on.
Mm.
It's not something that you work harder to make happen.
Which is
You have,
so hard.
yeah, it sure is. But
Yeah.
you have to learn how to calm everything down. And that's where honestly it's a journey. Tai Chi is a lifelong process. It's a learning process. They say you practice Tai Chi your whole life. That's because they've learned how to train the nervous system. So here's what's crazy. The Tai Chi people will say, in the West, we use exercise to get stronger, to get better cholesterol, to lower our blood pressure, to get toned, to lose weight. That's why we exercise in the West. In the East, they exercise to train the nervous system. So what I'm passionate about is both.
Mm.
We want to exercise to train the nervous system and the musculoskeletal system. And honestly, I love to combine spiritual training with physical training and put it all together.
Yes,
So,
that's the best way to that's so I love all of that. Can you tell us, and I know we're like running short, I could
yeah,
literally talk to you all day, but
same.
could we chat for just a second on what kinds of things help? Because you were talking about medications. I appreciate medications. What are your thoughts on medications in addressing these issues? But
Yeah,
also, I agree with the rehab ready thing. Like therapy
yeah,
needs to happen as well. So I would love to hear just a quick overview, and maybe we can chat again sometime and go in a deeper dive. But like
right.
overview, how to help with those issues that we were talking about.
So, like the lady I had this morning, wonderful lady. I've seen her 5 to 10 years. She's early 80s. She has BPPV that comes and goes. So BPPV, the calcium crystal problem, it comes and goes. And you have to put the rocks back, and then you try to prevent them, and there's things you can try to do to prevent them, but it comes and goes. So it screws with people.
Mm.
But she also has bad neuropathy, and she has macular degeneration, and she has bad neck problems, and she has heart issues and lung issues. And she just told me this morning how she gets so mad and irritated with people, and she doesn't know why. And she's just always mad and irritated with people. But whenever her and I get together, we like connect. I feel, we hug. Like she's this awesome lady, but she's running hot.
Mm.
She is not going to do Tai Chi. She is not going to. I have tried to set her up for nervous system training. I have tried to get her to exercise. She's not going to do it. I've sold it. I have done motivational education. I have begged. I have, you name it. She's not going to do it. So in her case, I think it'd be okay to talk to her doc about considering some medications that would help calm her body, maybe take the edge off a little bit. And maybe, I had another patient who's really battled depression and frustration. And again, it takes a special person who's willing to train their nervous system and musculoskeletal system. Okay. It takes a special person. That person might be somebody who's contacting you, because if they're contacting you, they're probably motivated to do that. But a lot of people, if we're honest, that's just not who they are. They're not going to train that way. So if we identify those people, I think it's okay to consider some pharmaceutical options. And then there are some cases where no matter how much nervous system training you do, they're probably still going to need some pharmaceutical intervention.
Mm-hmm.
So I'm open to all those options. I'm not anti one or the other.
Mm-hmm.
Personally, I love to explore non-pharmaceutical options. Some of my most high moments are after a good run at the nature center. And I get addicted to that. And I love it. But nobody's perfect, and we're all on this journey. And so there's nothing wrong with medication when it's needed. And so I work with the doctors and the counselors and the psychiatrists. And I love it when you have breakthroughs and you don't need it. But to be honest, I love it when a patient finds it and it gives them peace and they feel better.
Mm-hmm.
So
yeah. Okay. Thank you.
yeah,
That is good to know. And the different, like there are different maneuvers and things like you said that actual like therapies that you can do
yeah,
that will address those issues as well and
yeah.
that make a
And so
difference.
we're making up more maneuvers. Like people who listen to this, you might hear the Epley maneuver, the barbecue roll, the Seamont maneuver, the Guffoni maneuver, but we have other maneuvers that we do. And so if you still get triggered spells and none of those maneuvers work, you might need a custom maneuver for your own inner ear because your inner ear might be unique.
Oh, interesting. Huh.
Yeah.
Yes, we're all so unique. It can
Yeah.
be problematic, well, challenging sometimes. That's so
Right.
fascinating. Okay, well, thank you so much. I might, yeah, I'm like, man, there's so many questions I want to ask you. But why don't we just end with this? Is there a message, like anything that we haven't said that you want to have people hear who are dealing with this, who are struggling, who are like, I am so uncomfortable all the time and it's miserable. What's your message for them?
I really do think there's hope, but I'm not going to give false hope. I like to say we got to be cautiously optimistic. And overcoming these chronic symptoms from concussion or vestibular disorders is a process and it's a journey, and everybody is different. So if you're comparing yourself to your neighbor who got better in a month and you're not even close and it's been a year, don't beat yourself up. But there might be small tweaks. There might be things that can be done to make it a little bit better, to take the edge off. And with time and the right team, progress can be made. So
Perfect. And speaking of the right team, can you tell us how people can learn more from you, get in touch
yeah.
with you?
So if you want to come and see me, we do have people who come out of state who come and see me in Canton. You can email me andy.beltz, so andy.beltz as in zebra at aultman.com, or you can call our clinic at 330-363-6215, 3305. If you are a healthcare provider, I do teach these courses. So you could just email my personal email, just my last name, beltzandy1. So it's beltzandy1@gmail.com. Then I have a YouTube channel, so you could just Andy Beltz YouTube and you'll find me there. I have a LinkedIn, again, you can search me on LinkedIn. I had a website and then my domain it's a long story. So now I have a blog. It's fightdizziness.blogspot.com.
Okay.
But those are some ways. I think if you Google me, you can find me.
Yes. And we'll link all of this in the show notes too. So
Thank you.
yeah, absolutely.
So yeah, but I'd love to try to help people. I'm passionate about it. And I really appreciate you having me on. And it was really nice meeting you.
Thank you.
And I'd
It's
love to
so
do it
nice.
again. If you want to do a part 2, I'm open to that.
Yes. Okay. Perfect. Good. Thank you. I was hoping you would say that, but I would love to pick your brain some more because it is such a common concern that people are dealing with this. And it's just, as we talked about before, it adds to the layers of complication that is PCS recovery. So
Yeah.
I love your perspective, your experience, and your passion for it. It shines through. So thank you
Thank you.
for all of this, and we will chat again.
Thank you, Bethany. I appreciate it.
Thank you.
Bye, everybody.
I'm so glad you listened in today. I hope you have gained some helpful insights and inspiration regarding dealing with and recovering from concussions. My goal is to create more awareness and education about concussions and the fact that there is so much that can be done to improve life after someone has had one. Help me spread the message by liking, commenting, rating, and subscribing to this podcast, and share it with others who would benefit from hearing it. There are more resources available on my website. And again, if you or someone you love would benefit from concussion coaching, sign up for a free consultation using the link in the show notes or at my website, www.theconcussioncoach.com. Thank you. See you next time, and take good care of that amazing brain of yours.